Hello and welcome to the Neurology Nuts and Bolts podcast, a podcast all about constructing your career in neurology. I'm your host, Sara Schaefer from the Yale School of Medicine. Today, as part of the Finances of Practice series, we're going to be talking about inpatient billing with Marc Nuwer, Department Head for Neurophysiology at UCLA and a national expert on billing and coding, and Keselman, Associate Professor in Clinical Neurophysiology, Associate Program Director for Clinical Neurophysiology, and Neurology Quality Officer at UCLA. I'd like to remind our listeners that we've done a few podcasts within the Finances of Practice series, one on RVUs, episode 15, and one on outpatient billing and coding, episode 20. And it would be helpful to listen to both those episodes before listening to this one, if you have time. Thank you for joining us, and thank you for taking the time to speak with us today, Marc and Inna.
You're welcome. Happy to do so.
So let's start with the basics. You just saw a patient in the hospital, and you go to the billing section of your electronic medical record. Big picture, what kinds of categories should you be thinking about first for the types of codes that you're going to be putting in?
We think of the families of coding as being those that we choose first, and then we choose within a family a level of service. The families are inpatient admission, hospital follow-up, consultation, and then there's a couple other types of services that might occasionally be used: critical care codes and emergency department codes. Then within those families, you have to sort out what level of service. Once you've decided on the family and level, then there is a specific CPT code that you use. Hopefully your electronic medical record system gives you a descriptor of those.
So we're going to get into the levels in a little more detail in terms of billing by level, in terms of time-based billing versus medical decision-making based billing a little bit later. Can I clarify a couple things? So this may often come up for neurologists that they consult on a patient who's in the ED and it's unclear yet whether that patient's going to be admitted to the hospital or be sent home or admitted to observation. Would that be billed as a consult or as an emergency room visit?
If they are just in the emergency room and not admitted, then they are an outpatient. And if you're a consultant for the emergency room, then you're going to treat that as a outpatient consultation. If you're taking on primary care of the patient in the ED, then you can use emergency room codes, which that's a family of 5 levels of service. If the patient is admitted before midnight, then you're going to be treating this as a hospital code, even though you're seeing them hours before they were admitted. So the service in the emergency room becomes an inpatient, either admission or consult. Those would be the two main things you would use when you're just admitting the patient.
Got it. And I assume that if you code this incorrectly, or you think the patient's going to come in, but they end up going home or leaving AMA or something like that, then the billing department is going to be able to fix that on the back end for you. Is that correct?
Generally, that's true. The coders will look at what you scored it as, believing that the patient was not to be admitted, but they got admitted to somebody else's service, and now that service you provided at 2 p.m. in the emergency room has been converted to an inpatient status. The coders will take your outpatient code and translate it into the appropriate inpatient code, in part depending upon how well you've documented your service.
So the next thing that you need to decide once you decide if it's an inpatient service, a consult service, or you're billing as an outpatient because the patient is still in the ED and not admitted, then you have to decide if it's a new patient or a subsequent encounter. Now, in the outpatient setting, we talked about new versus subsequent encounters or new versus return patients in terms of whether that patient has been seen in the previous 3 years by anybody in your department. What are the criteria on the inpatient side? Does it only count for that particular admission if the patient was seen a week ago on the inpatient side by neurology for another reason? Is it still counting as a new patient this time around? And what about whether it's been seen by a resident or house staff member versus by an attending?
The 3-year rule applies to outpatients. The rule for whether it's been seen before by a member of your group for inpatients applies to each hospitalization separately. So if you're admitting the person to the hospital and nobody from your group has yet seen the patient, then you are doing this as an admission. If it's a consult in the hospital and nobody from your group has seen the patient yet during this hospitalization, then you bill it as a consult. The rule is peculiar in that in some circumstances, you see the patient in outpatient clinic at 10 in the morning, and they're an outpatient. You would refer them for admission to the hospital. They are then admitted at 2 in the afternoon. Now, everything done that day converts to inpatient. If you are admitting them to, let's say, the cardiologist service because their complaint in the clinic was chest pain and you're concerned about a heart attack, you're a consultant. Even though you saw them 4 hours before, you're still a consultant. If the patient is discharged from the hospital, then they may end up readmitted to another hospital or to a different hospitalization at the same place, but a week later. All of those are new hospitalizations. For example, you were caring for the patient in your regular acute care hospital. The patient's now being transferred to rehab, where you will continue to see them. The rehab hospitalization is a separate hospitalization. You admit them to the new hospital. It's not a follow-up, it's an admission.
And I take that to mean that, anybody who does inpatient consults has been in a situation where somebody may be hospitalized for months or a year, and over time, neurology has been reconsulted here and there, maybe even for vastly different things that have come up over the course of the hospitalization. I take your description to mean that all of those would count as a subsequent encounter. Is that correct?
Yes. Once you only get one shot at having the code called consult, and everything else in that hospitalization is hospital follow-up. I could mention that there is also some peculiarities about insurance companies. Some insurance companies, like Medicare, will not let you use the consult codes. So when you try to use it in your electronic medical record system, it'll get flagged as you can't use that code. What they're really saying is groups like Medicare want you to use the code for admission when you're really just doing a consult, possibly a week or two after they were actually admitted to someone else's service.
What about if the patient has a headache and 2 weeks later has a stroke?
So even if they have a different disorder, like a headache and now 2 weeks later a stroke, that follow-up is a hospital follow-up visit. That's a problem with long hospitalizations. People might have different disorders. As long as it's the same hospitalization and somebody in your group has seen them before during that hospitalization, then code it as a hospital follow-up.
Okay, let's talk a little bit about the language. So in the outpatient episode, we talked a lot about E&M codes, EM codes, evaluation and management, also about CPT codes and ICD codes. Some of this applies to the inpatient side of it and some of it doesn't. Can you do a real quick overview of the alphabet soup that we need to understand on the inpatient side of things?
It gets confusing for people because they don't realize that E&M are a subcategory of CPT codes. So when your coders or your auditors are talking about the CPT code for a service, they might be talking about a procedure like spinal tap, and they might be talking about an E&M. The evaluation and management codes, that category is bureaucracy speak for patient visit. All of your patient visits are evaluation and management, or E&M. And the codes you use for an E&M service are CPT codes for E&M. At another time, we might talk about other procedure codes that go on, such as doing a chemodenervation, a spinal tap, an EEG, an EMG. Those all have CPT codes for the procedure done. Today, we're mostly talking about E&M CPT. But your question raises the other interesting issue that the reimbursement to a hospital and to a physician group is often based not just on the CPT codes that you use, it's also based on the diagnostic codes you use. So how does that happen? Well, when you're coding, you select, well, for E&M services, you'll select an E&M CPT code, but you'll also identify what diagnoses are occurring for that visit, for that patient. Some of the diagnostic codes are specifically labeled as more complicated kinds of services. If somebody has a stroke, that's going to be coded as a more complicated diagnosis than if somebody's complaining of and being diagnosed as having a headache. These complexities will result in greater payment to the hospital and sometimes to the physician group. Diagnoses are lumped into families called hierarchical codes, HCC. The HCC codes are families that define how complicated is that patient's problem. And the more complicated the care of the patient, the more money is paid to the hospital or the physician group. Medicare has a particular group of HCC that they use. It's their own peculiar ones. We call diagnosis-related groups, or DRG. They pay the hospital a specific fee depending on what diagnosis was used. In other words, what diagnosis-related group applies to that hospitalization. Somebody admitted for a craniotomy will result in a hospital payment that is greater than that admitted for a migraine headache, which makes sense. Medicare lumps their payments so that most craniotomies would be paid at exactly the same level. Most patients admitted for a headache would be paid at exactly the same level. So your diagnosis counts when you're talking about how much money goes to the hospital. The physician groups sometimes have contracts with carriers that also use the HCC codes to reflect how much money you're going to get. So be careful when you make diagnoses. You want to choose ones that are most appropriate. In some hospital billing systems, they will list which diagnoses have a higher HCC category. And I think they're doing that to encourage you to use the higher categories if either a higher or lower would have applied to that patient. We all know how patients come in and they might have 10 different diagnoses. The billing system wants to make sure you're not missing some that could result in the hospital getting a higher payment.
So it's important to be truthful about what diagnoses a patient has, but to make sure that you're billing the ICD-10 diagnostic codes or connecting those to your CPT codes at the highest acuity that is true and relevant to the patient. Makes a lot of sense. Now, you mentioned levels of billing, level 1, 2, 3, 4, 5, just like on the outpatient side of things. Can you briefly discuss the time versus medical decision-making based structure of the levels? And also what counts towards your time? On the inpatient side, the language that I've been able to find is a little confusing. It says that time-based coding is when you're on the floor where the patient is, but what if you're going to another part of the hospital or your office or even home and still making phone calls and documenting the care of that patient? Does that count?
Yes, the rules changed in January 2023 so that the rule about being on the same unit as the patient no longer applies. Now, a physician counts all the time that they spend for that one patient, all the way from the beginning of the day until midnight. But at midnight, your carriage turns back into a pumpkin. You have to do the time that you spend that day before midnight. So it's everything you did for that patient, talking to the patient, examining them, reading medical records, talking to the nurse, talking to the family, talking to another physician, writing your note. That all counts. If you're the attending in a service that has residents, then the time that the residents are presenting that case to you counts. I would say, though, that if you're in with residents and you're just doing general teaching, that does not count. So this has improved our situation compared to past years, because in past years, if the patient left the floor to go to radiology and you were on the floor talking to the family, it would not count.
I'm glad that it's been fixed to actually be truthful to the reality of inpatient practice.
At the same time, the amount of time that's spent for each service changed. Based upon a survey of physicians, the times that it took to do one or another of these increased, so that for hospital follow-up, it used to say 35 minutes for the highest level, but now it says 50 minutes for the highest level. So yes, you can include all the things you did, but to use time to claim the highest level requires the amount of time you spent that day to be 50 minutes or more.
So whether you bill by time or bill by medical decision making, and we can talk about some of the special cases as well, like critical care billing, there's always that little blurb at the end of your note that you have to put, your dot phrase or whatever that says you spent this much time or did this and that. And it changes depending on what the requirements for what you write change depending on what CPT code you're using and whether you're billing by time or medical decision making. Can you talk a little bit about what is required in your documentation at the end of your documentation?
Well, if you're going to bill by time, it's easy. If you're going to bill by medical decision making, it's complicated, and a lot of people would find it hard for many patients. So time becomes a commonly used way of doing the billing. For billing purposes alone, all you need to say is the patient, the chief complaint, anything about what you did, and then say the total time today spent on this patient's care was, and list the number of minutes. For hospital follow-up and hospital admissions, there's only 3 levels. So a 50-minute follow-up would be billed at level 3, the highest level. If you want to bill on medical decision-making, then you're back to having to decide about factors such as the number of diagnoses that were under consideration that apply to that patient, the amount of data that you reviewed, and the risk of the complications or morbidity and mortality from what you're recommending or prescribing or ordering. In the old days, we used to be able to include the risk of the disease, but that's no longer the case. This had to do with number, data, and risk of the orders. So that in that way, it's similar to what we discussed for outpatients in order to get to high levels of complexity or level of service. Most people will, especially early in their careers, just simply use time. And as you go about developing your career, you will find there are certain ways in which you can diagnose and document particular kinds of problems using medical decision-making and taking advantage of having learned how the complexity applies. A number of things that we neurologists deal with are ones that do have significant complexity. So on many occasions, we are at the moderate or the high level of service. But as an example, for the first medical decision-making rule, which is number, you get to high medical decision-making if the patient has a significant risk of morbidity based on their own diagnosis. Morbidity, in turn, is defined as something that's expected to last a substantial duration, meaning many months or longer, and the disorder limits the patient's function or impairs their quality of life or may damage organs in a persistent way. So because it includes impairment of quality of life, many of our neurologic diagnoses do that, and the rule for numbers is met by saying somebody has a disorder that affects their quality of life and may cause impairment, such as MS or epilepsy. To be able to get to your level of service, you also need something else. It can't just be my patient has a seizure disorder and is still having seizures. You also have to be able to meet the rule for data and the rule for risk. Rule for data is complicated. It means at least 2 out of 3 and I'll give you the categories they count as the 3. Independently reading an image, in other words, independently looking at the MRI and judging on your own what you think of it. That's one element that could be used. The second element is discussing the patient's issues with another physician outside your group. So let's say you have a patient in the hospital, you pull up the MRI and make notes about your impression of that MRI, and you discuss it with the primary physician on the service. Well, that's 2 out of 3 of the rule in the rule of data review. The risk of testing also is something that a neurologist often is able to achieve. To get to high risk of morbidity from your tests or your treatment, you have to consider what are the things you're recommending. If you're recommending the use of a drug with an FDA a black box warning, then a black box can get you high risk. In other words, I'm prescribing Lamictal. There's a risk of Stevens-Johnson. I have to be very careful about that. That's a risk to the patient. Another risk has to do with recommending surgery. That would be something that involves risk. For seizure disorder patients, there's an FDA alert that says all patients have a risk and need to be closely monitored if using an anti-epileptic medication, need to be watched for depression or suicidal thoughts. That's a risk. So when we cause a risk through our treatments, that fulfills the third rule for medical decision making. So you need 2 out of these 3, number, risk, and data, to get to high. You can see why now I said that most people at the beginning of their career, in fact, many people for their entire career, will choose to use times.
Okay, I have a specific question about the documentation for time-based billing, because, there, in the past, it's been, you have to say that greater than 50% of your time was spent with coordination of care and counseling of the patient. Is that still the case, or can you bill just for everything all at once without making those specifications?
That's an old rule that has now been retired.
Excellent.
We're very pleased to see that disappear. It's part of the initiative that began about 3 years ago in Medicare to simplify the rules. In simplifying, they got rid of a lot of hassle factor.
Review of systems is also gone, correct? Review of systems has gone out the window.
That's right. Because if you recall what I've said here about medical decision making, it has nothing to do with having enough bullets to your exam. It has nothing to do with review of system. It has nothing to do with family or social history. It has nothing to do with the number of points you've hit in your history of present illness. All of that is gone. So we've gotten rid of history and exam-based level of service. Now it all has to do with medical decision-making or time.
Okay, so let's shift gears here and talk about how to bill to reflect what you might do above and beyond a level 5. So if you do time-based billing, I know there are time addition codes that you can do. There are different codes for advanced care planning, and I'm not actually sure whether that gives you additional RVUs. Can you talk about how to maximize your billing to reflect what you're actually doing for inpatients?
Yes, there's a fair amount of our neurology patients where the amount of time you're spending on that date exceeds the upper limit of what is hospital follow-up time number for that service, which is 50 minutes for a hospital follow-up. You have an option, if you spend at least 15 minutes extra, to code it with 2 codes. You code hospital follow-up, highest level of service, and you code the prolonged service code. And those codes you can use if you've done at least 15 more minutes and you document it. And you're going to use 1 unit of service for prolonged service. What do I mean by unit of service? Well, if you had done 15 and another 15 of extra service time, you could build 2 levels of service for prolonged service.
So I'm going to pitch the next question to Inna, since you're the Associate Program Director for the Neurophys Fellowship. How does billing change when the patient is seen by a medical student, a resident, a fellow, or I don't know if you work with APPs like physician assistants or nurse practitioners. When you're the attending co-signing their note, what documentation is needed? And in the case of APPs, how does billing work?
Right. So I'll do the trainees, and Dr. Nuwer, if you want to do APPs. So no matter how long your resident or fellow spends with the patient, you cannot bill for a time-wise. However, if you spend that medical decision making, that comes into the play here. Let's say they spend 2 hours, but you only spend 5 minutes, then you can, time-based will be 5 minutes, but then you're like, how much decision-making did you actually put in? Then you can do decision-making. However, if they spend 2 hours, but then you spend 15 minutes discussing the patient with them, reviewing all the records, talking about the problem, then you can still do the time code, but it's your time. How much time did you spend if you want to do the time code? And it's for any level of the trainees.
What about documentation? The little blurb at the end of your note. I discussed the patient with the resident and I agree, blah, blah, blah.
Right.
What components are necessary there?
Oh, right. So you still have to document the same as before, right? You discussed it, you reviewed all the records, and then you agree with the assessment and plan. Also, if you saw the patient, so a lot of the times, let's say it's overnight and the resident is seeing the patient by themselves in the emergency room and they're going to discharge the patient. So because you didn't see the patient, you still have to document that you discussed it and you reviewed all the records, but because you didn't see the patient, you can't really bill anything for it. So you basically document what you did, discussed, but did not examine, or examined and discussed.
For residents and fellows, I know that, you don't have to, but a lot of attendings do write an exam and their own assessment and plan. For medical students, I think you used to have to write more than you do now. Can you specify what needs to be documented specifically by the attending when you're co-signing and billing on a medical student note versus what can be documented exclusively by the medical student?
It's true that they've relieved us of the burden of having to write again what the medical student has already written. But at the same time, they've also relieved us of the responsibility for writing anything in the note.
Right.
So that still leaves us with a note that has to include all the important things just for good medical care. We've been talking a lot about the note as it is used for documentation of levels of service and families of service, and have you met the minimum time requirements. All that bureaucratic use of a note really has to become the secondary purpose of writing a note. The real purpose is for good medical care and documentation of what you need to remember or need to tell somebody else about your thoughts. And to that extent, the medical student note can reflect a lot of what has been understood, as long as I think the dot phrase that's used after a medical student note is often called the linking note, because you've linked your note to their note.
And what about for APPs, Dr. Nuwer?
That's a different rule. There's a move toward allowing you and the APP to both use the same documentation, but you have to put in enough about what you did to show that you provided more than half of the care of that service. And once you've provided more than half of the care, then the time-based billing becomes yours to do. If your note looks like the APP did most of the service and you're basically co-signing it like with a resident and just put a little brief note at the end, then it becomes the APP as the owner of the note, and the APP bills for the service. So it's heading toward who did the largest amount of the work for that patient for that date, and whoever did that, the note belongs to them and they can do the billing.
And if you're doing medical decision making, you have to comment that that you were asked. Correct. You were asked to see the patient and contribute to the medical decision making due to the complexity of the case. That's what I've been taught. Is that the way to go?
The exact wording isn't set in stone, but you do have to give the impression that legitimately you did a lot of the work, and a lot of the decision making is yours to have made. You show that you were a serious contributor to what's being said and done. It could be that you and the APP are both involved in the case, and in the end, you want to roll their time into your total time today for that service. Since they're a member of your group, you roll together or aggregate total time today for members of a group. Same thing occurs for other physicians. You see the patient in the emergency room, admit them, and now your colleague in the ICU is seeing the patient, and each of you writes notes. Because you're in the same group, you can't both bill for the service that day. You're going to have each one or the other of you will bill for the total time today for everybody in your group, including the APP.
In the outpatient podcast episode, we talked about how does one learn more about billing, and some of the things that you brought up were the AAN seminars on billing and coding, buying a CPT code book so you understand what all the CPT codes are, and talking to your billing and coding person at your own institution. Any other resources or resources that are specific to the inpatient side of things that either of you have used or would recommend to our listeners?
I think some of your own institutional courses and billers try to train those who are doing the billing at your hospital, and those can be helpful if you are relatively new to a hospital or relatively new to billing, that you do have the opportunity to sit down with one of those knowledgeable coders and go over your tactics, maybe review several of your actual notes and be able to learn what it is that you need to do and what parts of your notes counted toward coding. They can be helpful in getting you also to understand that coders are not physicians, so they don't always understand everything we're talking about, and they might not understand all the nuances of the medical issues you're dealing with. So they might not, for example, understand the risks of your orders or the risks that the patient has for morbidity from their diagnosis. So you sometimes have to spell it out in your note if you want the auditor to be clear on it, which is something that avoids trouble for you later on.
Anna, anything to add to that?
Yeah, I think having templated notes, and then maybe even sitting down with the billers and coders and saying, this is what we write for those purposes, I think very helpful. Not just the attestation, like I spend that amount of time on the patient, but even within the note, I think it's very helpful.
Yeah, in terms of morbidity, of a treatment, if you're an epileptologist prescribing Lamictal a lot, putting a dot phrase in there that talks about counseling the patient about the, likelihood of Stevens-Johnson syndrome, et cetera, might make things a little easier for you day to day, right?
Correct. Yes.
Yes. So documentation is not just about writing your notes for you to remember next week what you were thinking last week. It's also to document the complexity of what you're doing, the difficulties that are there, so that another person could look at your note and realize what you're thinking. Frankly, sometimes even physicians from other disciplines, like a surgeon or a family practitioner, might not realize some of the subtleties of what you're dealing with as you think things through. To a neurologist, it becomes second nature. But unless you write it down, somebody else might miss the point of what you're dealing with.
Very wise. I'll be sure to spend more time thinking about that in my future documentation. Thank you both for sharing your thoughts with us today and your knowledge about this very complicated topic. I appreciate you taking the time.
Thank you so much.
You're welcome.
Neurology Nuts and Bolts podcast was created and produced by myself, Sara Schaefer. It is not recorded as an official podcast of any institution or organization. The podcast is unfunded. Opinions are those of the individual participants. Music by Audrey Nath, artwork by Shivani Ghoshal. Want more content like this? Be sure to subscribe to the Neurology Nuts and Bolts podcast, wherever you get your podcasts, to hear more about constructing your career in neurology. Follow us on Twitter at NeuroBolts and on Facebook at Neurology Nuts and Bolts to stay up to date on new content and give us feedback on what you want to hear, and tell your friends and colleagues. Thanks for joining us.